Hi, I'm Dr. Padda. I'm a board-certified anesthesiologist, interventional pain specialist, addiction and obesity specialist. I know that it seems odd that I'm talking to you about nursing home care, and it would seem, what does that have to do with anything to do with interventional pain, addiction, or obesity? And I have to tell you that over the many years that I've been working in my fields, there's a common nexus of information and logistics that I've come across. And I think that we've created an amazing program that can really help patients in nursing home. And I've been managing patients in nursing home care for a long, long time. There's a couple things that I quickly discovered when I was helping my colleagues in the nursing homes, because they brought me in because they had complicated pain issues and they had compliance issues. And anesthesia is one of these fields that is all about compliance. It's all about figuring out systems and why and checklists and trying to create those things that get your plane off the ground safely and keep you in the air and keep you from crashing. And so that's how I ended up in this field. I'm going to talk a little bit about CareGuard. CareGuard is a unique program that we've developed that really accentuates and helps your nursing home and your skilled facility and your assisted living facility. There are a couple of elements of CareGuard that are why we got into this. One of the key elements is that we wanted to make sure that we could address quality of care issues inside of facilities. We wanted to increase health span and lifespan for patients. We wanted to improve the patient engagement and the family engagement and the facility. That triad of patient, family, and facility is critical because the patient may not have decided they wanted to come to your facility, but the family did. And the family doesn't necessarily want their loved one in the facility because they have a lot of guilt. And so this constant interplay between the guilt and the patient needing care, the family being unable to provide it, and then their constant worry that the facility isn't taking good care of somebody. And we've all heard horror stories. The other issue is, though, that how do you differentiate yourself? How do you differentiate yourself as a facility, one compared to another? Because those JCO certifications and those facility examinations that occur every other year, everybody gets similar scores. If you're open, you got a similar score. There's no way to really differentiate. And you certainly don't want to rely on Yelp and things like that, reviewers that are just horrendous and essentially blackmail you into giving them money so that you would rise to the top of the list. You want real, authentic information. We've created a program that does that. If you have a CareGuard certified facility, the patient will know, the patient's family will know, and you will know, and your staff will know that there is a way to report issues. There's a way to take care of issues in the facility that's non-confrontational. This drives reduction in liability. This improves your interactions with your insurance company. And we've put this in such a way that it's part of a patient care organization. So everything that we do is a legal work product. And it allows you to have affirmative defenses. What do I mean by that? Well, let's say that you offer CareGuard at your facility and your facility is CareGuard certified. The patient's family declines to participate. And then Uncle Joe, who didn't even know that someone's in the facility, shows up a year later saying, oh, they're taking horrible care of my uncle, or they're taking terrible care of my grandfather, or this person that I haven't even seen in a year has had horrible care. And it's usually driven by guilt. It's because they didn't come visit, they haven't followed up, they haven't figured out what's going on, and they're not the ones that are paying the bills usually. These people come in and they come in at the end going, oh my God, I can't believe there's a wound there. They must be nursing home neglect. And all the while, the patient has dementia, the patient has an inability to move, and you're doing everything you can to improve outcome. And of course, we know that things aren't perfect. What we want to do is address that, because as an affirmative defense, you can say, look, we offered a CareGuard 360 program. We offered the opportunity for anybody that would notice a problem, immediately report it to us, and then we can immediately address it. And if you fail to report, if the person who put the person into the nursing home fails to report, or if a caregiver fails to report, That's a defense. It says, hey, we have a reporting mechanism that's non-confrontational. It doesn't go to the local manager. It goes to ownership. It goes to our legal department. It gives you that affirmative defense that you know that you've done the right thing. One of the biggest fears of nursing homes is, how do you gain patients? How do you one, get patients into your facility, and two, how do you keep them from leaving your facility? CareGuard certification allows you to differentiate yourself. It makes you stand apart from the rest of the crowd. So people will go, oh, okay, well, at least we know that somebody is laying eyes on this facility every single month, not every other year, every single month. So that means that the local management is not suddenly gearing up a week before 2 years from now to make everything perfect for the JCO inspector. It means that every single month, somebody's looking, and it's a non-confrontational way to do it. It improves your patient retention because we make sure that the patients aren't getting infections. We make sure that they're not getting upper respiratory tract illnesses. We make sure that we keep you safe from the Department of Justice, because if one of your patients has an STD and transmits it to another one, or God forbid, an employee transmits it to a patient, it's considered abuse. And so we want to make sure that you reduce your liability, that you can differentiate yourself, that you can retain these patients and increase your revenue. Because we all know that nursing home care and the bottom line is shrinking. And I'll talk about that during this conversation. So our program is designed for early detection and intervention. It's designed to optimize patient care. We want to reduce hospital admission, and we want to reduce the cost of patient recruitment. That's one of your biggest costs. The average time and the average money that it takes to recruit one patient into your facility is typically 1.5 months of rent. It's 1.5 months of income for that patient bed. And that's what you're going to pay a patient recruiter. And that's pretty typical. Now, you might be down to 3/4 of a month. You might be at a month. You might be at 2 months. But typically, it's about 1.5 months. That's a lot of money, because in a facility, that is $4,000 or $5,000 a bed. And if you have a 90% occupancy and you have 10 vacant beds, if you've got 100 beds, that's $40,000 or $50,000 expense. And if there's a better way to do it, and there's a better way to recruit, and there's a better way to hang on to your patients, that's much more cost effective. Now, the doc that you have that is probably covering your facility, they're probably not looking at it the same way that the ownership and the management group is. They look at it as, I'm providing a local service, and I'm just going to come through here and see these patients, and I'm going to get out as fast as possible. But they may not have been trained in the compliance rules. They may not be thinking, how do I prevent people from getting UTIs? I know that if they get a UTI, a chunk of them, 35 to 40% of them, go on to get urosepsis. And if they get urosepsis, they end up in the hospital. But they're probably not thinking, if they end up in the hospital may not send the patient back to the facility. We want to gain patients from the hospital that they want to discharge. We don't want to send patients to the hospital, because the hospital doesn't want to discharge a patient back to a facility that had urosepsis, because if that patient bounces back, the hospital gets hurt by Medicare. There's a global period, and if the hospital gets a bounce back, it's a problem for them. So they do everything they can to analyze their partners out in the field and say, hey, which facility has the least amount of UTIs? Now, let me give you an example. You give somebody a general broad spectrum antibiotic if you think they've got a urinary tract infection. 30 to 40% of the time, if you don't know what they actually have, the antibiotic could be wrong. It could be a fungal infection, not covered by antibiotic. It could be a facultative anaerobe that's not picked up by a regular culture and sensitivity. And the days of doing CNS, which take 3 to 5 days to get results, are over, because you miss a bunch of the facultative anaerobes. The same thing occurs with upper respiratory tract illness. If you have one person in your facility with a URTI, that means that everybody in the facility is exposed. And these people are typically bound in the facility, so they're not the ones getting the problem. It's usually the staff or someone that came to visit that brought that upper respiratory tract illness into the facility. Now, one of the other things is, we know that there's a long period of senescence, and that senescence is when a lot of patients end up in nursing homes. If we increase the health span, though, and we can improve the outcome, that period of senescence, if they're already in the nursing home, can be reduced as in terms of interaction and requirement and severity of disease. And we're able to take care of the patient for a much more efficient way. We're able to reduce our cost of care. We're able to get better outcomes, less cognitive impairment, and yet they're still in our facility. They can age in place safely. If these patients become early senescent and they have early death, that's less people in the nursing home. What we want is we want to have the healthiest nursing home population we can get. We want the ones that are least cognitively impaired after they get to us, because the reason why they get to us is they were cognitively impaired. So we want to actually reverse disease. And that's a novel concept in nursing homes. Most people look at nursing homes as a warehouse. That's where you put the product on the shelf and you just wait. That's not how we look at it. We know that if you do the appropriate lifestyle and behavioral health and appropriate medication deprescribing, these patients can do better. They can live longer and they can have an improved health span and lifespan. And we can improve how they interact with their family.